Dr. Su-Ting Lee is a national expert in educational research. Dr. Lee is a professor, associate vice chair of education and residency program director at UC Davis Health in the Department of Pediatrics. She is a young blue, so go Bears, as being a Cal graduate. She received her MPH in epidemiology at University of Washington and her MD at UCLA School of Medicine. She is well published in education and well funded in educational research grants. So, Dr. Lee.
Thank you for that kind introduction. Can you guys hear me? Let me know if you can't, and I will try to speak louder. Great. So I have nothing to disclose. So we're going to start with defining Boyer's different types of scholarship, and then we'll move on to talk about Glassic's criteria for scholarship, and end with assessing how to incorporate higher level outcome metrics to strengthen your medical education project. So first we'll start with defining Boyer's different types of scholarship. So Boyer expanded the definition of scholarship in 1990 from a discovery of new knowledge, which is what we normally think about in academics, to the discovery of the scholarship of integration of knowledge, application of knowledge, and teaching of existing knowledge. So we'll go briefly into each of these. So the discovery of new knowledge, we're all familiar with that. Oftentimes basic science or clinical research, hypothesis-driven research. We may think about that for education. This is a study from the New England Journal of Medicine looking at a national cluster randomized trial of duty hour flexibility and surgical training. UC Davis is one of the sites in this study, for those of you that remember. So this is an example of discovery of new knowledge in education. Integration of knowledge. I think of that as synthesis of knowledge across disciplines or contexts. So I think of that in terms of systematic reviews or meta-analyses. So this is a systematic review of randomized controlled trials on the role of coaching in surgery to improve learner outcomes. And they found in this systematic review that coaching young surgeons did actually improve both their satisfaction as well as how they did in the OR. And then application of knowledge. So this is the translation of knowledge into practice, implementation science. I think of this as quality improvement, implementation science. An example of this might be the improvement of surgery clerkship using monthly feedback, face-to-face feedback, and anonymous surveys to then plan, do study act cycles and improve the rotation. And then teaching existing knowledge. This is really dissemination of existing knowledge in a scholarly way. So this example is implementing a resident acute care surgery service to improve resident education and patient care. So we're going to go over how to do this in a scholarly manner to describe Glassic's criteria for scholarship. So in 2000, Glassic took Boyer's expanded definition of scholarship and tried to figure out what are the criteria that make these work scholarly and what produces scholarship. For those of you that are potentially interested in publishing scholarship later, I've left a package of handouts in the back at the table on the outside, a checklist for authors that we created prior to educational scholarship manuscript submission. So I hope this is useful for you. I think it's been useful for the people that have used it previously with me. So Glassic's standards of quality scholarship include adequate preparation, clear goals, appropriate methods leading to significant results, effectively presenting those results, and then reflective critique. So adequate preparation. So in order to adequately prepare for your study, or winter is coming, understanding that gap in that knowledge, so understanding the literature first of all. And then you need to acquire those necessary skills, collaborators, and resources in order to actually do your study and obtain IRB approval and exemption. So first you need to understand your area of scholarship. So what has already been done? What are the gaps in the knowledge? And what gaps are actually important to fill? If you do that, that's already writing your introduction of your paper, right? And not only that, it ensures that the study that you're going to be doing is important. You can do this through a literature search. So you want to pick the right source. Many of us use Medline or PubMed, but if you're going to do educational research, you may consider expanding out to something like ERIC, which is an educational database. You might look at Embase, which includes European data, CINAHL, which has nursing and allied health data, as well as MedEd Portal, which has a lot of curricula in there as well. And Merlot has some multimedia resources, and Dream, while it was still in effect, had some assessment tools. You want to make sure you use the right search terms as you do this so you can find the articles you're looking for, and your medical librarian and the medical librarians here are very helpful. You want to acquire the necessary skills, collaborators, and resources. So as you plan your study, you want to think about, what do I need to do? What do I need to have in terms of skills, resources, in order to do this study? Do I have that expertise myself? And if I don't have that expertise myself, who can I collaborate with? Who can mentor me? Who can I go to and consult with? And that may be methodological experts. So it may be that you need biostatistical support. I collaborate with my biostatistician all the time. In fact, he's my jogging partner, so I run with him in the morning, which is really great. So I can ask him questions that time too. But it's really wonderful to be able to do that at the beginning of when you're planning your study, when you're beginning to think about that. So you make sure that you actually ask the right question and gather the right data so you can actually answer that question later on. If you're thinking about exploring something and you're thinking about qualitative research and using qualitative methods, if you're not a qualitative expert, pair with somebody that is. Be mentored by them so that the next time you do a qualitative study, you can be the expert. That's how I learned to do qualitative research. If you're thinking about doing surveys, the same thing. Pair with somebody, learn from somebody else, and then be able to do that yourself. If you're doing a project that requires simulation and you yourself are not a simulation expert, you may want to collaborate with somebody that is. And then think about what resources are needed in order to do your project. So that may be personnel, administrative assistant, standardized patients. You might need equipment. You might need the sim center. You might need some time to do this. You might need some space to gather all your learners. And if you're working with learners of whatever level, you may need buy-in from whoever controls their time. So that may mean making sure that the clerkship director has buy-in if you're working with medical students, that your residency or fellowship directors have buy-in and will allow you to use their learners if you're working with residents and fellows, and that the chair or vice chair for education has buy-in if you're thinking about working with faculty. And then IRB approval. So IRB approval or exemption is needed for any scholarship you plan on disseminating anytime in the future. So just do it early. Most educational scholarship will be IRB exempt or have expedited approval, but only IRB gets to decide that. You don't get to decide that. And as a journal editor, that's one of the first things that I look for when I review manuscripts. And then remember consent. Anytime you're the IRB will usually let you know, well, almost all the time let you know if you need to do consent. I'm thinking about, think about consent, particularly if they're using any identifiable information. So I did a study years ago when I first started out that the IRB here said, no, you didn't need to do signed informed consent from the medical students. And then some medical students complained about it later, and I had to go back and halt my study and get informed consent, even though the IRB had told me earlier that I didn't need to do it. So think about that for anything that's potentially identifiable, even if the IRB says, oh, no, you don't need to. So just think about that. So the next thing is clear goals. So one way of building those clear goals is, as you build your research question, think about it as an iSmart goal or an iSmart research question. So it needs to be an important question. Is this an important question to you that you're going to spend a lot of time on this? And is it important enough to the field that they're going to care about this and want to see this published? Is the question specific enough, or do you need to hone it down some more? Do you have some measurable outcomes that you can look at to help answer your question? And then is this achievable? Do you have the right resources to do this? Is this something that you have the expertise for or have the collaborators for? Is this relevant to the field? Will the answers actually add to the literature, or is it just rehashing what's already known? And then timely. In terms of timely, think about, am I able to do this in an appropriate amount of time for me? So as a resident or fellow, you want to finish it within your residency program or fellowship program. As a new faculty member, you want to do, especially for your first projects, you want to get something that's out, publishable, so that you can actually promote it, right? So you want to make sure that you start with something small, add to that, and grow. So some of the key components for a research question, you may think about this when we do evidence medicine as well. So a PICO question, so patient or population, what's the intervention or exposure, what am I comparing this to? So you want to think about a comparison group, and then what is the outcome I'm looking at? So for example, in general surgery residents, do flexible duty hour policies compared to policies with 16-hour or 24-hour shift lengths result in increased patient morbidity and mortality. And then you're going to look at appropriate methods. So your methods need to map back to your goals. Are the research methods appropriate to answer your goal and address your research question? So if you're asking a research question that requires quantitative methods, you want to use that. But if you're asking, I would like to understand this perspective, quantitative methodology is not going to work for that. So you want to use qualitative methodology for that. And then are your teaching or curricular methods appropriate? Are you using best practice models for curriculum development, such as Kearns? And we'll talk about that really briefly in a second. And do your evaluation methods map back to your learning objectives? So here's a couple of best practice models to help you really provide rigor by systematically organizing your work and incorporating evaluation as a central component of your work. So on the right-hand side is Kearns' 6-step approach to curriculum development, and we'll go over that in a little more detail. And then on the left side is a logic model, and that's oftentimes used for program evaluation and program development. And that one looks at input, so what are the resources needed, outputs, what are the specific activities or goals or curricula you're going to have people do, who do we want to reach in terms of our participants, and then looking at short-term, intermediate, and long-term outcomes. So again, Kearns is one of the best practice for curricular development. So if you're developing new curricula, this is a place to start. And with Kearns, we may start with problem identification and needs assessment. So what is the overall health problem or educational problem that we want to solve? Looking at the literature, looking at what's done nationally, what's the current approach? And then what's that ideal approach? And where's the gap between the current approach and the ideal approach? And that's what your research question should target. Thinking about a targeted needs assessment within your own department might be, okay, well, I know what the national needs are. What about here at UC Davis? Perhaps we're a little bit different in our department. So thinking about our learners and our learning environment and perhaps asking them. Using those to then develop your goals, your broad goals, and then specific measurable objectives that come from those goals. And then thinking about how am I going to achieve those goals with what educational strategies am I going to use. Then implementing it, making sure you have the appropriate resources and support for that, and then evaluating how well that's working. So one of the places to think about this, as you think about Kearns' 6 steps of curriculum development, is also where does your conceptual framework fit in? And a conceptual framework, has anyone ever heard of what that is? Awesome. So a conceptual framework is really a theory of learning that you have. So how do you think that that learning works? So we'll talk about that in a second. And then your evaluation, we'll be talking about a lot of time on this in terms of program evaluation. So when you hit your educational strategies, you may be thinking about conceptual frameworks at that time. And that should really drive your educational intervention. So for example, if what you're trying to do, for example, is I'd really like to improve my residents' ability or fellows' ability to do laparoscopic surgery. And I think that fellows learn best by purposefully and systematically practicing what they don't do well in order to improve performance. And for me, that's deliberate practice. So the framework of deliberate practice might be goal-directed task performance, immediate feedback from a teacher or a coach, revise that kind of mental representation of, oh, okay, I didn't do this quite right as a learner, so I want to do it this way instead, and then repeat and refine that. So you might be spending a lot of time in the sim lab initially, if this is the way that you're thinking that learners might learn laparoscopic surgery. However, if you think that people learn best by observing others and reproducing their behavior, and they're motivated to continue or alter their behavior based on whether or not they receive reinforcing or corrective feedback, and that learning occurs in a social context, you might be thinking about Bandura's social cognitive theory. In that case, you might want to put them in a place where they can observe others. Right? You might want to put them in a place where they can observe experts in laparoscopic surgery doing that and coaching them while they are in the OR. So that's a very different approach than the previous one, right? So your how you think people learn for that particular thing that you want to teach them is going to affect how you're going to do this curriculum. So sometimes when you go through Kern's 6 steps, you might actually come up with several papers out of this. So for example, as a needs assessment, this was a needs assessment that got published, and it was developing a national simulation-based surgical skills boot camp in general thoracic surgery. So they did a needs assessment, a national needs assessment of program directors and experts to see what do we need? What do we need to train these new CT surgeons or thoracic surgeons? So that's one step. Another one might be, I want to understand perspective. I want to understand what the barriers are to the implementation and the uptake of simulation-based training programs in general surgery. So you might do a qualitative study, and they did a multinational qualitative study. So depending on what your question is, you may have different studies that come out of that. Curriculum. You may be looking at curriculum development, developing your own curriculum, and how do you answer that? So this is association between simulation curriculum and learners' confidence and interest in CT surgery. And then all of us teach, so we can think about where we might do all of this stuff, right? All of us may think about, okay, maybe fewer of us, about the needs assessment. Understanding perspective might be useful. But all of us teach. So we may think, how can we do a better job with that? What kind of curricular developments, changes do we want to do with this? Do we want to study that Succeed program? Because that sounds really cool, right? And then moving on to assessment tools. We all assess our learners, assess our medical students, we assess our residents and fellows. Do we do a good job with that? Can we do a better job with that? This study looked at the reliability, validity, and feasibility of this Swish scale for the assessment of intraoperative performance. So this was specifically designed for surgeons. So next we look at significant results. So this cartoon is a bunch of people, scientists at the blackboard, and they're doing a whole bunch of work, and at the end they say, all that for a 6? 6? Big deal. What good is a 6? Well, the outcome of all your results should be significant. How important is it? Is it going to change, add to the literature? Is it going to be recognized by others? Is it going to make a difference? Do you build on the work of others? We all build on the work of giants that came before us. And can others build on your work? And so are you able to be rigorous enough in what you do so that others can build on your work, and that you can continue to build on the work of others? And you're going to ensure that significance by carefully evaluating your goals, the gap, the importance of filling that gap, all of what you did with that adequate preparation piece. So then you want to effectively present what you've found out. And you want to match your dissemination to the type of scholarship. So in order for it to be scholarship, you can't just do the research and not tell anybody about it. That's not scholarship. You know, scholarship without dissemination is not scholarship. So it needs to be publicly disseminated in some way. It should be peer-reviewed. It should be reproducible. And again, that's the rigor of which you conduct your study, as well as being able to be explicit in your methods and how you do your study so that others can reproduce it. And then it needs to be a platform on which others can build. And again, that rigor is important for that. And then dissemination. So identify your target audience and where you'll disseminate your work. Are you going to be disseminating on a print or online journal? Are you going to be submitting for a local, regional, or national conference? Are you going to be doing a workshop at a national conference? Are you going to be submitting curriculum to MedEd Portal? So if you're looking for a journal and you're not exactly sure where's the right place to submit your work, you could use Jane. So Jane is this journal author name estimator, and what you can do is you can put in the title of your manuscript. You can put in the abstract. You can put in some keywords, and then it'll spit out for you what journals have published something similar. So that might be helpful for you if you're not sure. Hey, I'm not sure who would be interested in this. Reflective critique. So you want to critically evaluate your work. This is oftentimes done in the discussion section of your article. You want to clearly state your key findings and place those findings in the context of relevant previous literature. And then discuss the limitations and the strengths of your work, and discuss some practical significance and implications for medical education, and offer guidance for future work and what you're going to do next in terms of your future directions. You want to value and consider the opinion of others to improve your work, and that includes when they come up to you with at your poster, when you're reading the critiques of your manuscript by reviewers. You want to really think about that and incorporate that into how you're going to improve your work, not only your current work, but your future work. So next we're going to look at assessing. So how do you go to incorporate higher level outcome metrics to strengthen your medical education project? And this is Kirkpatrick's pyramid, and we're actually going to talk about the New World Kirkpatrick, so there's a few extra layers in that. And that, starting from the bottom, is reaction, learning, behavior, and results. So I think about New World Kirkpatrick level 0, below the normal Kirkpatrick, is can it be done? And usually those can it be done studies are not publishable. But if they're extremely innovative, they may be. So this study was on the feasibility of real-time intraoperative performance assessment with SIMPLE, a system for improving and measuring procedural learning. And this was early experience from their multi-institutional trial. And they looked at a bunch of different programs that used it and looked at cumulative times they actually used it. And then they looked at number of times each week someone went in and actually logged the evaluation to say, hey, people can use this. It's actually feasible, kind of as a first start. Level 1 is really reaction. Did they like it? Kirkpatrick usually starts with just satisfaction, but the New World Kirkpatrick adds in engagement and relevance as well. So satisfaction, you might do this, but how would you rate your satisfaction with the curriculum? You might think about engagement in terms of how well did the teacher actively engage you in your own learning? And then relevance, how relevant is the content to your own practice? Are you going to use this later on? Some examples, so I'm going to, as I go through these New World Kirkpatrick's examples, I'm going to go through a pediatric example and then a surgical example. So the pediatric example is the one on the right, and that's development, implementation, and dissemination of the IPASS. So it's a handover curriculum, which is actually they're working on to continue to broaden beyond pediatrics and then have studied in surgery and internal medicine and other places as well. This low-level example, 81 to 96% agreed that their workshop promoted acquisition of relevant skills. So they liked their workshop. In this other study, looking at the association between simulation curriculum and learners' confidence and interest in cardiothoracic surgery, 82 to 100% of the participants rated the simulation as good or great in terms of effectiveness, so they liked it. And then 100% of the participants would recommend this course to a colleague. So that's pretty good. Level 2, this is really learning. Did they learn? So normal Kirkpatrick looks at knowledge, skills, and attitudes, and then the New World Kirkpatrick adds in confidence. Are they confident that they can apply these skills? And then commitment to change. So you can do this with a pre and post evaluation. Oftentimes, for a lot of those, we say everyone learns. People are smart. They're all going to learn post. But are they going to retain that knowledge? So you might want to do not just a pre and post, but you might want to do a 6 months post or a 12 months post in addition to make sure they retain that knowledge. So for knowledge questions, you can think about multiple choice questions as an example. For skills-based knowledge, that may be a simulation. For attitudes, that may be a survey again to see if their attitudes change in terms of the importance of that topic, their confidence in actually being able to do that surgery or do that procedure, their commitment to changing their behavior based on what they learned. So an example, again, looking at the IPASS curriculum on the right, 91 to 99% of residents agreed or strongly agreed that they were able to perform all aspects of the standardized handoff process. And in the CT surgery example, the curriculum increased their operative confidence in being able to perform common cardiothoracic surgery procedures. And of participants who were not confident before they started, and this included learners from medical students to residents to fellows, so probably more confidence increased the lower you were, right? So 75% increased their confidence by at least 1 point on a 5-point scale, and 39% increased their confidence by 2 points. And then behavioral change. So did their behavior actually change when they learned what they did and it was taken outside of the STEM center or outside of the workshop? And then what are some of the, added on from New World Kirkpatrick, what are some of the processes that reinforce, encourage, and reward behavior change? And I think that's a really important piece that I think really also adds into the quality improvement aspect of it. So a lot of things we can teach people, but do they actually continue to do that when we're not there hounding them about it? So you may think about that in terms of checklists or direct observation, and then you might consider qualitative interviews to try to unroof some of the processes piece or process changes that you might be measuring. So a couple of examples. The one on the right is the IPASS nationally, when they looked at the rates of medical error and preventable adverse events among hospitalized children following the implementation of the resident handoff bundle, which is the IPASS bundle, and they found fewer omissions of key handoff data, so they actually were able to perform that. And then this surgical study looks at spaced education improves feedback that surgical residents give to medical students, a randomized trial. So in this study, they emailed weekly to residents, surgical residents, a teaching tip or a feedback tip. And they found that that increased both the quantity and quality of feedback that medical students reported that they received from their residents. So level 4 is really the top of the pyramid, the return on mission, the results. What are the differences or changes in patient outcomes and learner outcomes? So these are a couple of examples looking at those at the same study for rates of medical errors and preventable adverse events. Found medical errors decreased with the IPASS bundle from 33.8 in 100 admissions to 18.3 in 100 admissions, and that physicians spent a greater amount of time at bedside. So it actually took less time, and they were able to spend more time at bedside with this handoff bundle. And then looking at that national cluster randomized trial of duty hour flexibility that you guys participated in several years ago, there was no difference in patient rate of death or serious complications in the flexible, less restrictive duty hour policies compared to the standard policy group. In fact, it was exactly the same. And then there was also no difference in resident dissatisfaction with overall education quality or well-being that they found there. So because of that, ACGME actually rolled back some of those restrictive policies based on this study. So some of my lessons learned as I'm doing educational scholarship, and I'd love to share with you guys in case it's helpful. So first, do meaningful and aligned work. So you want to really align your scholarship with your passions, what you're doing anyway, and then institutional or societal values. So this figure is comes from the Japanese ikigai, which I'm sure I'm pronouncing incorrectly, but it's an idea of do what you love, do what you're good at, do what the world needs, and then if they'll pay you for it, that would be awesome too. And then that would be like really the sweet spot, right? So think about that for you and your scholarship and what you're doing. So for example, when I came here as junior faculty, a long time ago. I came here straight from fellowship. I had done an academic general pediatric fellowship. I got an MPH in epidemiology, and I was interested in doing some research while I was here. And I remember sitting in my division chief's office, and he said to me, Su-Ting, you don't look like a diarrhea queen. And I was thinking, what in the world is he talking about? I'm not a diarrhea queen. Like, that's not what I'm interested in. That's not my passions. Well, when I looked at what I produced, I had a study on antiemetic use for acute gastroenteritis in children. I had another study on interception and oral poliovirus vaccination, looking for association. I had another study on loperamide therapy for acute diarrhea, which is a systematic review. I had another study on parental management of childhood diarrhea, and I was writing a grant for a randomized controlled trial for lactobacillus and diarrhea. Wow, that did not align with what I thought I wanted to do or my passions. Luckily, many years later, I've been able to do a better job of doing that. So I'm really interested in mentorship and building our next leaders in education. I've written some papers around personal mission statements and building your scholarly brand as well. Done a lot of national workshops on that. I was the chair for the council for the Association of Pediatric Program Directors for LEAD program that helped program directors and fellowship directors become educational scholars and leaders. So that's been exciting. I'm really interested in collaborative education research. And when I first started here, our pediatric program's not that big. We're a middle-sized program. We have now 39 residents total. So when I first started, I started doing scholarship with just my residents, which is, by the way, can be difficult to publish because it's not that big. And then I was able to collaborate with people nationally to do more work. This study here, I actually collaborated with a quarter of all pediatric residency programs nationwide to look at the study and look at milestone data from that study. So really great opportunities to be able to work with other people to do that, both here as well as nationally. So I've collaborated with people within the, internal medicine, psychiatry, here at UC Davis as well. And then I'm really interested in elevating or improving educational scholarship. I'm one of the medical education editors for academic pediatrics. And then we've written some papers on both how to do research as well as considering things like pre-registration of educational trials. Is that something we should do? Because we do that for clinical trials. So we need to protect time for scholarship. You need to carve out protected time for scholarship. It's not going to happen unless you make time for it. And often, as something that's important but not urgent, sometimes it falls to the wayside. So if you don't make that time and protect that time, nobody else is going to do it. There's always things that are urgent, but maybe not that important, that you can kind of lay aside for a little bit in order to do that. I've blocked out time in my week in order to schedule time that says research that I try not to put in anything else during that time. And it needs to be important to you. So what you're studying needs to be important to you, get you fired up enough that you're going to want to do this and not reprioritize it for something else. You want to plan. Everything takes longer, at least 3 to 5 times longer than you originally thought. Create a realistic timeline, but realize that timelines can be revised, and that's okay. Get down a contingency plan. Think about scaling down your project to something that's doable. Pilot it. Think about PDSA cycles. Pilot and revise. Again, don't be overly ambitious when you're first starting out. You want this doable within residency, within fellowship, within medical school, within the first year or 2 of your initial faculty appointment, because you need to be able to produce scholarship in order to get promoted. So doability is really important. Break your larger projects into smaller things. Like I said, sometimes that needs assessment is actually publishable. Sometimes, the curriculum can be publishable. Sometimes you have a project. I had this huge project and I got 4 papers out of it. Big papers, actually, but thinking about what you can do with each of your projects. Begin with the end in mind. So plan your analysis when you plan your study. Make sure that you meet with your biostatistician early. Think about what are measurable and analyzable outcomes, and make sure you collect it correctly and cleanly so that you can actually use that data later. Design your study so that your results are meaningful, no matter what the results are. So if it's important, if it's a really meaningful study, even if it's a negative result, it should still be publishable and should still be important. You can write a lot of your paper before you've actually completed the study. You've written a lot of your paper as you're thinking about the study while you've done your IRB, right? So you've written your introduction when you've written the introduction for your IRB, when you've done your adequate preparation time. In fact, I've done that sometimes, and I've turned it into a systematic review and published that. So thinking about, again, the pieces that you want to do. Think about, you've already written your methods. You can write that. You can make blank tables or blank figures with no data in it yet and label them and figure out how you want to organize the data, how you're going to arrange that, because it's going to save you time. It's actually going to help you later on. And again, get IRB approval before you start. Identify where you need help early. Look for resources. You have a lot of wonderful resources here in your department, a lot of wonderful resources outside of your department at UC Davis and nationally. A lot of mentorship there. Choose your collaborators well. Include mentees. So if you are a resident, think about including a medical student. Think about, as a faculty member, including a medical student or a resident or a fellow. Thinking about as a senior faculty member, bringing up one of your junior faculty members, because we can all improve together. Clear communication is really key. Discuss authorship really at the beginning of the project and throughout. So what are the criteria to be the first author? What is the criteria to be the senior author? And just make sure that people are meeting that, or if they don't have the time to commit to that, that they are okay with rejuggling that. Think about responsibility charts and timelines, and then regularly schedule meetings. So when I collaborate with a group of people or people, I regularly schedule meetings. I don't leave the room until I know when the next time we're meeting, because everyone's busy. And then I don't leave the room until we know what our action items are and who's going to do what before our next meeting. And whether that's like in person, or I've done a lot of national collaborative stuff with Zoom or other things. And then my take-home points. So scholarship includes more than just discovery. So think about scholarship of integration, application, teaching. All scholarship have a common set of features. Use Glassix criteria to make your work scholarly and to transform what you do every day to educational scholarship. Develop a clear research question. Think about why that's important. And then your methods and results should map back to your research question. And then aim to incorporate higher level outcome metrics into your scholarship, because the higher those level outcome metrics are, the more likely you will both make a difference as well as get published. So I'm happy to take any questions. And again, if this is interesting for you, I have them in the back, if that's useful.
So thank you so much. So this is really incredibly, realistic, doable suggestions, tricks that make doing these things easier. And I really love, we've seen the sort of Japanese match your life with your work and make that cognitive dissonance go away when you're really not the diarrhea queen. Although I could see that in you.
Yeah,
it
I know.
happen.
It could happen. I almost went that way, right? I was really close.
Exactly. So we have a little time for some questions. Happy to, Dr. Rack.
So I think that it's great that you set the mentorship and the sort of defined goals and calendaring of those. You know what I mean?
Yeah.
Having the regularly scheduled. You really want to hear me louder?
Absolutely.
Oh my God. One honest person. So, but it really is critical to set these time points, because many of us, and I've been certainly guilty of this, want to do something, really want to do it bad, but life gets in the way, right? So you've got to set the time, and actually having collaborators and mentors helps you to keep to that schedule.
Totally does. Right?
Because they have the expectation that you're going to show up that day and you're going to have something prepared that you're supposed to prepare. The one thing that one of the thought leaders in congenital heart surgery continually brings up is peer review should happen before the study happens. And I wonder if you could comment on that, because we don't do that.
Yeah, I think that's a great thought, and if that's something that you can build within the Department of Surgery, that would be amazing and wonderful to be able to do, especially for your younger faculty or younger residents and fellows in terms of having other people review your work. We've started off and on thinking about that in pediatrics for grant submissions and having other people review your work before you submit for a grant, especially for junior faculty. But thinking about that before you submit a manuscript as well, I think is really helpful, because there may be other people that have been really great at that area and can really help thinking about that. And then going back to your other point, Gary, what I often will do is figure out when I want to submit something and then work backwards from there. So for example, I know that Pediatric Academic Society abstracts are due January 1st or something. So then I will go backwards from there and say, okay, in order to do that, I need to finish writing my abstract by here, so my final copy here. So then I need to have my first, one of my drafts here, and then if I'm collaborating with people, I need to have enough time that they can actually get back to me to do that. So then I need my, data analysis done here, and then I need my, data collection done here, and then to move back. And then I look at it again and go, is that realistic or not? Like, is that something we can do? And if that isn't, then we revise it. But it's a good way of thinking about that. I do the same thing for papers. So we have a paper that I want to get out before the Christmas season now, and so we went backwards and did that now. And so now we're on, I think, a really good next draft, so hopefully we're going to be fine for that. But thinking about how you're going to do that, and for me, it's working backwards.
I think working backwards, so surgeons in general work really well with deadlines. Spectrum out.
Yeah, I really enjoyed your talk and how you distilled everything down. As I was listening to each of your points, I thought, yeah, I learned this from that person. Yeah, I learned this from that person. I mean, these are all really important lessons. I wonder if you could comment a little bit more about building up a scholarship portfolio. And when I look at others, research questions, there's always two things that in my mind, make a research paper really good. One is if it's important regardless of what the outcome is, whether it's positive or negative. And the second is if whatever you do leads to something else, so you can sort of build not only build from others and others build from you, but that you can build from your own work and really develop a research portfolio. I think it's important that as we develop academic careers that we're not a mile wide and an inch deep, but that we actually develop a niche. I wonder if you could comment a little bit about how you went, because you obviously developed that even though you were sort of headed in a different direction.
So one of my mentors when I was a fellow used to have on his computer and on his room focus, so to remind you to focus on it. And I focused too much on diarrhea. Like, you have to step back first and make sure you're going the right direction, and then I think to focus, but recognizing what is it that you're interested in. So for me, I'm interested in improving self-regulated lifelong learning, and for me that's a huge piece of it, and there's a lot of different aspects of that to build on that. So think about what is the big piece that you're interested in. I also have some interest in improving resident scholarship or scholarship during residency or fellowship. And so I've had another area of research in that, and I've collaborated with a lot of people in that. We've built on that, which is really nice actually when you do collaboration, because we've done, and we're publishing a paper on that soon in terms of how we've built that research collaboration. But it's several of us from multiple different institutions started to do a study on resident scholarship and how to improve that, and then that built into 4 or 5 other studies. And with that, different people took the lead on them and was able to go to the different strengths. But it was all on the same sort of idea of research of resident scholarship. So that was really nice that there was a lot of people that were able to take different leads, and we were able to support them. I was the senior person on all of those, but I was able to support a lot of the junior faculty as they've now risen up into associate and full professors.
So just a quick question. How many years did it take you to switch from diarrhea to
I know, right?
education scholarship?
Yeah, right. So here, so when I came here in 2003, I was, part of my job was clerkship director. So I was the pediatric clerkship director for several years. And then sometime during that time when I was out on maternity leave, the residency program director called me and said, hey, Su-Ting, and I was on maternity leave, are you thinking about maybe you're interested maybe in resident education? Maybe that would be great. Would you like to be think about being my associate program director? And how do you go from there? And right around that time, a little bit before, after that time, I came up for my in between merit, so between when you go from assistant to associate, and they do like a partial
Mini
review,
review, yeah.
the mini review for you. So they looked at it and they said, you're doing a lot of service, way more service than you need to be doing at this point. And that was like a lot of committees, a lot of other things, but your research isn't, you're not doing it. You're not cutting it with the research. You need to focus better. And part of it, I was collaborating on like things with diarrhea. I was like all over the place, right? Like you said, I was doing things with EMR, which was working so slow at the time. I just couldn't do any EMR research. And then I was like, well, none of those are really my passion anyway. So let me just start doing this. And I started it, and I started slowly, and then switching over. I'm a pediatric hospitalist, so I still do some pediatric hospitalist medicine research because I mentor others in that. So I mentor some junior faculty members in that. So I still do a little bit of that, but the bulk, 80% of what I do is really education research. And so building on that, building collaborators, which is so helpful to get your work done because you only have so many hours in the day, right? And you want to sleep during some of them and eat during some of them and maybe take a shower every once in a while. But, so some of that is like doing research and being able to do that and still seeing your family. Right?
So just want to say that your transition from, diarrhea to education is an opening for you there. Practice it out. Dr. Djokovic.
First of all, thank you for the slide on the Jane reference source. I actually didn't know that. I'm amazed. Is that new or is that?
For a few years
Yeah.
now, but I think it's
That's a polite
really.
way of saying.
I think it's really useful. It could be really useful because there's a lot of us where we're like, okay, once I get thinking about a couple of different journals, I'm not sure where to go after that, right?
So number one, thank you for that. Number two, I'm going to ask you if you have any insight into how best to deal with achieving IRB approval for a project. I think many of us, when we particularly involved in multi-institutional trials, see wide variability in what IRBs at different institutions around the country will approve, and may have some hurdles at UC Davis to obtain IRB approval. I'm wondering if you have any insights into how to proceed with that step.
That's true and true. So I've done a lot of multi-institutional studies and where I write the IRB. The first one I did, I actually wrote the IRB for many of the other people's IRBs because they didn't know how to write an IRB for their program. And then we had it, so we did the IRB kit and then had them adapt it to their program. I think for me, what's been helpful has been sometimes, if you're not sure, calling the IRB and talking to them and having them talk through different things. And then I also have templates of ones I've used in the past and language in terms of what I've used in the past. So if you are doing a study, an educational study on medical students or residents, and somebody else in your department has done something similar and has gotten that approved by the IRB before, see if you can borrow some of their language because you're doing probably the same sort of stuff in terms of the language that the IRB wants to see in order to do this study. So thinking about that as well as oftentimes I will call them up and talk them through that because they'll send you back and forth like emails of what they like or don't like, but they don't make it much sense. And so it's really hard sometimes. So sometimes I'll just call them up and say, so what do you mean by that? What can I do? This is what I meant. What do you mean by this? How can I change this to make this work?
I think we surgeons aren't good at asking for help very often, and this is a reminder that in fact there are lots of places to get help. And the more you ask, the more you have people that are on your team, and that makes a difference.
And that may be something that you guys think about doing here in terms of if somebody is doing this type of study, who else has done kind of the IRB in that already and could potentially lean that out. So I've done that for my residents as well and said, hey, I've done this, an expedited review on this or a survey on blank. This is the language I've used.
I was just saying to Dr. Djokovic, I just got back from Vanderbilt, and there's this big building that's the whole survey center.
Oh,
The expertise around how to do surveys. I thought, I don't know, I thought surveys were easy. But no, there's lots of different kinds of surveys. So
yeah, what's
that
the
was
validity
educational
evidence?
to me.
What's the validity evidence for your survey as you think about that? Yeah.
Dr. Lee, this has been wonderful. I have a comment and then a question. The comment, I think, is very instructive that you talked about your appraisal process and that you did a sort of a research reboot or redirection of your goals, and that was 3 years roughly 3 years into your time here. I think that's very instructive that at that point it's not too late,
It's not too late.
to do a reassessment and then launch a really successful research career. The question I have is you talked about how some residencies are very small and it's very difficult to do studying that small population. We actually have multiple residencies in this room, CT, plastics, vascular, that are modest-sized residency programs. Outside of a national collaborative, what type of studies, if any, can be done for such a small residency program?
So it was really interesting. I was not as familiar with the surgical literature until I researched this talk.
Really appreciate it.
So I tried to use like surgical references there. So interestingly, there are, because people in your field know that residencies or fellowships are that small, that they are fine with smaller studies in those places. Whereas for us, those might not work as a full study, but might more work as a scholar innovation. So scholar innovations are also great. One of the things that, I had lots of studies I had up there and I had to pick and choose because there was so many great things that surgeons have done in terms of educational research. I was just amazed with all of it. One of them was crowd sourcing. So I was using crowdsourcing in order to evaluate a procedure and comparing crowdsourcing with in terms of rating I don't know if it was a laparoscopic procedure or something, to expert, like 10 faculty experts. And they found that the 10 faculty experts, that was what they used for their gold standard, and it took them 24 days to look at all of those stuff, and they could get the crowdsourced answers back in 24 hours, and the mean results were the same. So it was very interesting, and that was done in one like urology residency up in Seattle. So I don't think those are that big either. So
So
thinking
you
about
can
those
videotape the
pieces.
resident and then crowdsource it out to the rest of the department and say, who do you think did it best?
Well, yeah, and it was laparoscopic, so it's
Okay,
de-identified. So it's de-identified, right? So you don't
Yeah.
know which resident it was at all.
Wow.
So it was pretty cool, and so there's a whole bunch of research on that area now. But there's a lot of cool things I think that could potentially be done, even with small programs.
I see a big smile on Ho-Fan's face, so beware, trainees. Something that's coming.
Lots of cool stuff.
Thank you so much. This was
Okay,
really
thank
great.